Ricardo Aner, my good friend, to present his nice lecture. Yeah.
Okay, Ricardo, you are ready, Ricardo? Are you ready? Yes. Perfect.
Can you guys hear me well?
Yes.
Yeah.
So thank you, Luis and John, for organizing this. It's a pleasure to be sharing experience and learning from you and from all of you. I'm gonna try to share with you a little bit of our experience with complications with flow diverter on the acute. So I defined that on the first 30 days, and this is the team. Those are my disclosures. There's no question in my mind that flow diversion is a revolution in what we do. When we have a complex cavernous aneurysm like this, to go from there to here, it's just phenomenal that we can fix this and have a permanent occlusion that used to be one of the weakest links of endovascular. There's no question all tools fail. Even if a master is dealing with a very high-end tool, and for those of you who are younger, you don't remember this guy, but my bias count, best pilot ever, even on his hands, the tool, Ayrton Senna, even on his hands, the tool did fail, and unfortunately he paid with his life. It's a bad analogy to compare surgeons to pilots, because typically if the plane goes down, the pilot is with the plane, and here is not, it's somebody else's plane that is going down. But we gotta use these fails to learn and develop better tools, and I think we're doing that in endovascular and microsurgery. Those are the tools available for us in the US is Surpass, Pipeline, and Fred. We don't have Silk, TourBridge, P64, and others. They're all a little different. I'm gonna skip for that sake of time. And I think that potentially some of the complications are more prone, for example, ischemic complications with dual layer devices versus a treated device, a flow diverter with anti-thrombogenic agents on the wall. That is remain to be seen, and unfortunately, we don't have head-to-head comparison with these tools that hinders our decisions. Naturally, there's a series of issues on we're treating aneurysms with flow diverters. I'm going to focus just in two of them. I'm going to focus in ischemic events and what Luis asked me to talk about, bleeding, because there's more emotion there, and the ischemic events are boring. The delayed aneurysm ruptures are very intense and unpredictable. But I think it's important to talk about ischemic events because that is #1 complication for all studies of flow diverters. And I think if you look at these 3 studies that we were involved, PUFFs and a late phase and an Intrepid and Aspire, you have here the number of patients treated. But you see here, when you look at the complication of that, and I'm not going to go through all of that for sake of time, but if you look at the complication of all 3 series, #1 cause was major ischemic event. So the name of the game is complication avoidance. Once the ball hits you on your face, it's very hard to avoid the issue. So we got to play smart. For me, #1 is patient selection. Again, if you look at this patient here, this is probably a patient that you might even consider not treat the aneurysm. Look at the GRE series on this MRI. This guy has little bleeding on all bunch of ischemic / hemorrhagic strokes that he had on the past. Yes, she has a giant aneurysm, but you got to discuss with the family what is the best, and maybe a parent vessel sacrifice is as simple, and avoid using of a dual antiplatelet on this. But when you decide to treat the aneurysm, I think it's paramount. I don't do, and I'm glad to hear from Pascal and Shubin, I don't put a patient on the table without checking my Plavix function. And I'm a firm believer that if this number is high, you're asking for more complication. And there'll be a lot of discussion that we can have about that. And also be aware that when you substitute clopidogrel for ticagrelor or prasugrel, there's also resistance. For me, and this is the last slide on ischemic, I think it's about case selection, case execution with the access that you and the way you handle the device and the way you place the device. I think these numbers are getting better. We're getting smarter collectively. I think we learn how to deal with these tools. And in every study that we do, you see a decrease on these complications. So we're collectively, we're learning how to handle this. And the devices are getting better. And the devices are coming out with surface modifications we don't have in the US yet, but in Europe, you guys have pipeline flex. And you also have the Phenox P48 with hydrophilic coating, and to come yet, the Baby Silk Vista with P8RI. We're gonna learn and we're gonna be able to see this better. If the device is not well against the wall, you're gonna have more trouble. And one thing that I think is very interesting, you see clot formation on the side branch with OCT that we don't see with angiogram. This is just an example of dissecting aneurysm that we treated with a off-label compassionate use of shield. And here you see the resolution of the aneurysm over time. Next 10 minutes, I'm going to talk about what is the most feared, in my opinion, is the delayed aneurysm rupture. Was first reported in 2010 with a silk. And this is very typical profile. The aneurysm is treated, the aneurysm is thrombosed, 5 to 10 days later, the aneurysm bleeds. Have we seen this before? Yes, again, this happens through other modalities. So we've seen this with carotid ligation, we've seen this with bypass. This is a case of mine with this horrendous basilar. This patient got a VP shunt, 48 hours, we're preparing to treat this, 48 hours she bled from possibly mural destabilization, natural history, nobody knows, but this can happen with other modalities. But we know with the stenting, this is probably more troublesome because we're changing flow. And this is not a flow diverter case. This is a case that I was involved in, was a fellow in Buffalo. So this is Nick Hopkins treating this vertebrobasilar junction aneurysm that he treated with a coronary stent. And this is the movie of the coronary stent flow change. You see that he created a jet on that aneurysm. We're happy, we got the stent there, got out of there. This lady came back 5 days later with a subarachnoid hemorrhage, very similar to what we see with flow diverter. And now you see on this video, after a second, this is coronary stent, guys. This is 2001, way before flow diverters. You see that you slow down the aneurysm flow. And this is this lady 3 years later when she came for clipping of an MCA aneurysm. You can't tell that this aneurysm was there. So we know this happens, and that's why I put this as the main topic. Most of these ruptures, and this is a super nice meta-analysis done by Mehi Rochaud, together with David Calms, and he identified 81 cases at this time in 2006. Most of these ruptures occur on the first 7 days. About 70 to 80% of them on the first 30 days. Couple of different reasons for this to happen. Again, we can perf the aneurysm, and we just talk about that when we're doing coiling. Some of these aneurysms are really challenging, and we're going inside the aneurysm, around the world, loop of wire. And if you look at the Matt Guinness OCT on that, any wall manipulation of the vessel, you are damaging the endothelium. This aneurysm wall is already troubled. Any change on that, any touch on that could destabilize and lead to rupture. You can have abrupt flow change. There are very few case reports of an aneurysm rupture right there when you place the flow diverter. I know Pedro has one. There are very few cases that a rupture happened right there. But many cases of device malposition lead to rupture, and I'll show you that. What Adam Arthur coined the term fat man pants syndrome. You put a flow diverter and the thrombus gets swollen and just tears the aneurysm. But I think the number one, in my opinion, is a thrombolytic cascade leading to mural destabilization. Every time you have a clot on a blood vessel, there's a proteolytic cascade trying to break that clot, and that ends up digesting the vessel wall. This is uneven coverage. If you're interested on this topic, I suggest Shapiro's website. neuroangio.org. You see here, if you put a 5 millimeter pipeline in a 3 millimeter vessel, you have all this uneven coverage. This happens through all devices. Naturally, it's more reported on pipeline because it's the most used device. We don't have a precise denominator to say if this happens more with A, B, or C. In my opinion, it happens through all of them. I'm going to show you a couple of cases. This is a case that came to us, dissecting vertebral aneurysm treated by a colleague. Here you see the problem. He treated this with a pipeline, but if you look at this picture already, see that he did not seal the inflow. So this is a concept of endoleak. The flow is going to come around. You cannot leave this like that. You got to extend your cover more proximally. You got to put a bigger device. You got to use a different device. And some devices now come up to 6 millimeter. So you got to play smart. You cannot leave this like that. So when this patient came to us, she was already on the phase of complication. But when we reviewed the pictures, you can tell why this happened. So this is what happened. The aneurysm bled. It was an unruptured aneurysm. It bled. And then when it came to us, all that we did, we just put another device in, extend the coverage, come way down here. Now we got to make sure that you have that. So you see here, the first device was ending there. We just got a bigger device and went more proximal and fixed the situation. That's more uncommon. This is more common, and this is the substract of delayed aneurysm rupture after flow diverter. Is a carotid aneurysm in general ophthalmic with a large / giant aneurysm with a neck that doesn't look that bad. I can tell you, Yuha is going to look at this and said, I'm just going to clip this. And that's reasonable. She failed a BTO, and in my hands, she would need a high flow bypass before clipping. At her age, I decide for minimally invasive. And you see here, the neck is a wide neck by definition, but compared to the aneurysm, not so much. So I treated her in the early phase. She was my case 51 of pipeline in 2011. And here you see single device, very similar to what we saw with that coronary stent. I create a jet, and we don't know what that means till today, but it has a nice stasis on the aneurysm. I'm really happy. I do MRI in all these patients, so she has a little bit of a scattered DWI. You see here the aneurysm before, here you see the aneurysm after, with the aneurysm, a lot of thrombus inside the aneurysm, and there you see T2 bright on that. She went home 3 days after. 5 days later, she comes back. This is what was described there before. In Germany, this is a very similar case to that. She comes to us. You see here, there's no flow on the aneurysm that is visible on a CTA on the angiogram, but I'll show you that regardless of the presence of thrombus, you're going to see there are clefts of flow inside the aneurysm that we cannot detect on a CT angiogram. So she has a pipeline in place. We put an EVD with a stealth guidance. I want to make sure my EVD is on the perfect place without unnecessary manipulation of the brain. Didn't stop the aspirin plebis, and we wait. She was a GCS of 4. I didn't think she was going to survive. 3 days later, she's following commands, and then we go for an angiogram. And you see here that you see these clefts of contrast penetrating. So there is blood going all the way to the top of the aneurysm. Put another 2 flow diverters, she survived. And if you go back and look 2 months later on this CTA, she ruptured right at the dome. So even though we only saw filling here, see the daughter sac that got created there from the pseudoaneurysm that ruptured. She ruptured at the dome, not elsewhere. So she recovered, and this is her follow-up angiogram a year later. She survived that with a complete occlusion of the aneurysm. She got disabled because she had an ACA stroke. The ACA was already compressed at the baseline by the aneurysm, so there was low flow there when she ruptured. She had an ACA strip stroke and suffered from that. This is the case that Adam used. I think I showed this because it's uncommon for us to see, and there's a picture of his authorship. You see this VB junction aneurysm or proximal basilar trunk through a third ventriculostomy. So you see here the basilar, you see the aneurysm, a very cool picture. He discussed with many of us this case. He decided for flow diverter and sacrifice of the left vert without coils on the aneurysm. And if we had to do this case today, probably we wouldn't do that. I think we learned with that. And you see what happened here. That's what he coined that term, fat man pants syndrome. He said it's not a regular rupture, it's like a whole tear on the aneurysm. This is autopsy. Naturally, this patient didn't survive. We saw this at PUFS, one case, and I'm gonna skip here for sake of time. Again, this is reported in all series on PUFS, Aspire, Intrepid, up, and I'm gonna show this picture here. And we're talking about giant aneurysms. That incidence is not 0.6%. If you look at the whole series of 906 aneurysms treated in 793 patients, that number is 0.6, but that is a skewed number because if this aneurysm is under 10 millimeters, that number is 0. But if the aneurysm is over 25, that number is 4.5%. So if you're dealing with a large and giant aneurysm, you've got to be aware of this. Why did it happen? There are clot factors, there are hemodynamic factors. The timing is probably different, the mechanism why this rupture happens. And I think if it's on the first day, I think you have one of the first 4 that we define here. But on this delayed, for me, is clot formation, stretching the wall, and this proteolytic cascade. I'm going to skip this for sake of time. Possible solutions. We do use, for giant aneurysms, increased neck coverage and coils. And you see here from the meta-analysis, again, denominator is a problem here, but you see the majority of these cases had no coiling associated. Very nice paper done by David Combs and his lab. When you put coils together with flow diversion, you decrease this metalloproteinase levels, so the coil can decrease inflammation. And you see that it's not perfect. There's another case of ours, very similar case, giant ophthalmic, neck not so bad. We treated with coils and flow diverter. This was primary operator, my partner. If it was my personal case, I would put a second, maybe a third flow diverter. We treated with one flow diverter and coils. And this lady came back 7 days later with a headache. You see that she ruptured at the dome. Thankfully, if you look at the coil mass here, right against the parent vessel, you see here after the rupture, the coil mass saved our life because the coil mass moved up and tamponed the vessel. Today, when I have to treat these patients, we have careful counseling. We have to discuss other modalities. Some of these cases can be treated in a different modality. I think we should consider in some aneurysms, like the one I'm going to show you here as the last case, impossible to stage. But if you can stage, coil, let the clot stabilize, and then come back and finish with the flow diverter, that's a valid strategy. This is a lady with 2 giant aneurysms, a carotid T and an ophthalmic. So you see here, again, that same profile, neck not so bad, giant aneurysm. We end up treating her with coil of the distal and flow diverter, and coil of the ophthalmic and flow diverter with 2 devices. And this is her at follow-up with complete occlusion of the aneurysm, a little bit of an endo leak here that got better on the follow-up angiogram. So in conclusion, I think the early complications with use of flow diverters can be decreased. Case planning, patient selection, antiplatelet management. Delayed aneurysm rupture is a concern for sure. It's totally related to size. The bigger the aneurysm, the more common for this to happen. Counseling and strategies needed to decrease those complications. And we just started, I cannot be in an international crowd, we just started the campaign for the title number 6 towards Qatar 2022. Before Qatar, we stop in 2 weeks for LNC. Everybody's invited to share this experience, October 23rd, 24th, 9 a.m. Florida time. Everybody's invited. One more time, Luis, thank you, gracias. Great to be with you guys.
Thank you very much, Professor Hanel. Your presentation is fantastic. And your topic is very difficult. There are many. I think every case is different. The patient, every aneurysm is different, and it's not. I think it's not simple to prevent the risk of the rupture. The first question is why the rupture is 1 week later in general. Why? First question. The second question is the thrombus in the aneurysm and a cascade of the thrombotic mechanism. Why not to use to prevent with not only with anti-aggregation, with another anticoagulate or another stop to the cascade. And the final where is different to compare the monstruous or giant aneurysm to the standard or medium aneurysm. Sometimes in the giant aneurysm in the siphon, you are a pre-stenotic lesion. And this pre-stenotic lesion close to the neck, you need to predilatate this. And this manipulation is possible. You have a lesion in the wall of the vessel, is my opinion. What do you think about?
I'm just gonna. So here, Luis, I think you just mentioned that. I think you're spot on. I think you have, and I think every single paper in brain aneurysm, microsurgery and endovascular should define up front what aneurysm you're talking about, because to compare a 27 millimeter, 30 millimeter ophthalmic with a 7 millimeter ophthalmic, they don't belong on the same sentence in terms of risk profile of any of the treatments. So if again, it's very hard when you put all cats on the same bag and call them aneurysm. It's very complicated. I think it's misleading because again, the lady that I show you my case 51 with pipeline that she ruptured, I did quote to her a 1% delayed aneurysm rupture. I totally misled her on that. If I told her this was a 10%, that might be a different discussion with the patient, but I didn't know better then. But today we know, and we need to do that. I think it's past the time that our journals and every single thing that we do in terms of presentation should be talking about size first. And you see here on these risk factors, my studying of that and review of literature, you see here apparent vessel stenosis, as you said, it's there. So if you have a pre-stenotic or a post-stenotic, you are more prone for this delayed aneurysm rupture. I think it's very hard, and I agree with you, every case is different, but there are, I showed you similarities that we can play smart and we can learn from each other and prepare for that. Today, if I have a giant ophthalmic that I decide to treat endovascularly, and if I can just coil the aneurysm, I will tell the patient this is a 2-step procedure. We're gonna coil your aneurysm. And some of us, like Saruhan, will tell you, oh, at least 6 months. I think that's a arbitrary number. I tell the patient a month or 2, recover from the first procedure. When you're feeling strong, we'll come back and we'll finish that, because the coil, we know there'll be a 40%, 50%, even if you coil perfect that aneurysm. But we have a series of cases that got coiled and treated with the flow diverted in a delayed fashion. And on those, we haven't seen rupture. So that has to be considered. And
Ricardo,
on your fit,
Ricardo, yeah, yes.
I just wanna.
No, you said no. If one question, and if you in your department you are one expert neurosurgeon to bypass, for example, being true, some case in the to discuss the best treatment, some case it's difficult to endovascular the giant aneurysm, or you are a stenosis, and probably the first choice to treat is the bypass, no? Surgical bypass.
Yeah. Yes.
I think it's important to.
Actually, if the it's a neck, if the neck was quite narrow, I prefer to clip it directly. And if it's a very giant fusiform aneurysm, I may use high flow bypass combined with ICA proximal progressively occlusion.
I think another day I organize a session of the choice to the difficult case aneurysm to treat it maybe with bypass. Pascal, what do you think? Will you have a comment with the flow diverter and
great lecture as always with Ricardo. He's the pipeline master. I think we've learned a lot since we started, and I think Ricardo agrees with me. The case he showed, the giant ophthalmic, if he's doing it now, he would have coiled with it. At this point, I would have any intradural aneurysm above 10 millimeter, I would coil with pipeline, and sometimes we would do it delayed, or sometimes we would do it at the same time. But again, I think this would decrease the risk of rupture. Otherwise, like in any new device, you know, at the beginning, you have a lot of use. There's a peak, everyone to use it, and then it plateaus. And now we know really what cases not to use it for. Definitely, it's a great tool. And but as Ricardo said, any tool has limitations. We cannot do, one size fits all, and it should be tailored procedures, and we should use all the tools.
But in my experience,
Yeah. Ricardo.
Just a minute, 35 patients treated with onyx, high density onyx. Never I have early rupture. Why?
Well, because Onyx HD 500 is different, right? Because you're not.
Of course, it's different.
Like you're coiling.
Yeah.
But tell me how many parent vessel stenosis
Why?
you have?
No.
But Luis,
every time I use in the 20 patient, the final, I use the stent. No,
Luis,
standard. Yes.
I can pull up a picture here of a giant PCA with onyx that ruptured post onyx HD 500. So
1 week.
Again, from giant aneurysms that I've been involved with onyx, maybe we did 10, 15. So 1 in 10 is 10%.
But so, Ricardo, it's a different concept.
No, different concept. And we explored this. I think maybe
only it's different technique, not concept. The concept is the same. It's treated aneurysm. This is the concept.
The same. In one case, you're filling the aneurysm like coiling, and the other case you're waiting for the aneurysm to thrombose.
Why I stop the onyx in aneurysm? Why?
What?
Because why I never use it. Why?
Hard to use, Luis. I think that's, for me,
it's hard to use. Yes, of course, but this is not the reason. Not this. It's another reason. It's hard to use. It's hard to compare the surgery of Professor Hanarimi. It's hard also. It's not. It's not the device. I think it's another discussion in another week. Okay. Next presentation. Another comment to the audience
Okay, I have a question for Ricardo.
Yes.
You mentioned that. You mentioned that some endo leak from the proximal end of the stent of the pipeline. So, what kind of maneuver you would take after you found this endo leak?
Yeah, I think if you have a bigger device available, that's one. Again, you can try to angioplasty the device, Shubin. But again, the number one thing here, you got to identify that. You cannot finish a flow diverter case without being 100% sure that your device is against the wall. If you have any questions, it is your job to finish that. It's just like finishing clipping for those that are surgeons without making sure that you are the base of the aneurysm. You got to see the other side. You got to maneuver. You got to look around. For us in endovascular, for me, you can use cone beam CT. I think is a great tool, but the native picture, different angles, get the bone out of the way, rotate, till you said, no, there's no question. I'll just give an example. On Premiere, high-end operators in a clinical trial, knowing that this is going to be to a core lab. There were 2 cases out of 141 that the aneurysm was not covered by the pipeline. So that tells me, reading into that, it can happen to any of us, but we got to be careful. We got to make sure that we're covering that. You cannot finish a case like that. When you look back, it catches your eye immediately that the device didn't cover. So you can, like I did on that case, just make the construct longer. And if you have a bigger device, and that's a shortcoming of the current generation for us in the US, the device goes up to 5 millimeters. So if the vessel is 6 millimeters or for us larger than 5.25, that's not a good tool to use. You gotta use something. Elvis Blue goes to 5.5. Surpass can go bigger on the Streamline and not on the Evolve. The new pipeline is probably coming with a wider, and there are other devices that we don't use, but you gotta make sure that you have the proper, if this vessel is bigger than 5.25 today for us with pipeline, not a good option. If it's bigger than 6, we gotta look for other tools. With Surpass Streamline that we have now in the US, because of the different nature of that, when you compress the Surpass, it does get wider. So I've treated vessels up to 7 millimeters with the Streamline, and that's a good tool to have around. You gotta learn your tools, and there are many countries represented here on this screen. You gotta know what you have available at your local facility. But I think you gotta recognize that that's, I think, number one.
Okay, thank you.
How much are the costs of this treatment? You put 3 stents and huge number of coils.
Yeah.
It's extremely high numbers. I was working 1 year in Nepal. The people didn't have to buy a clip for the ruptured aneurysms. They went home, Lama.
Yeah. I think you
in China, pipeline is $70,000. So if you push several pipelines and then huge number of coils, then costs are so high that only very rich people can pay that. Did you ever think about
so
that?
I
In
think
China, you have 5 million aneurysms, I have counted. So if you want to treat them with these high costs, so I think even in the richest countries, you are losing a lot of money, or there's no democracy in the treatment of the patients.
I think it's a great point, Juha. I'm born and raised in Brazil. I'm very familiar what you're talking about, and I push as hard as I can. And I think we all should push, because for the patient, it costs $70,000. For the maker, it costs $200, $300. So there is a movement in the US, capitation of cost. If you use 3 flow diverters and 30 coils, there are places already doing that you don't pay more than $10,000 for all the devices, or $15,000 for all the devices. I think this should happen, especially for those countries that cannot pay that. And I think it's a very valid point that this needs to have a per patient cost. We try to run this clinical trial in China, because I think I would love to see if using 3 flow diverters change indeed this delayed aneurysm rupture occurrence. You just mentioned that we got stopped because of the cost, and I think it is our job to push to get this to happen at accessible cost for everybody.
The less expensive.
One more question. One more question. What is your experience in the giant atherosclerotic aneurysms of posterior fossa?
Yeah, we are
dealing with them.
I think the experience there is not good. But with that said, on our last 4 cases, Juha, and we're about to publish this together with AJ Wakalu and others, it seems that, and I think Luis touched upon this, since we start doing this with triple threat, as I call aspirin, Brilinta, and low dose DOAC, Xarelto, Eliquis, the results seem to be less terrible. Let's put like that. I have, from these last 4 patients treated, they're all 4 alive, and one of them had a small ischemic perforator stroke, the other 3 did not. And we're talking about people now over 6 months from treatment, and 2 of them with about a year or so of treatment. So, but that's a terrible, terrible problem. I always, I'm humble, and I think there are people out there advocating treating them when they are asymptomatic. It's a hard decision to make, to put somebody. But if you look at the Christian Taschner from Germany, with his experience, the results seem to be better if you treat these patients asymptomatic, but I think it's hard to justify touching such a bad disease with an asymptomatic patient. Your thoughts on that, Juha?
I hope Reza Behnam Yahrami will get his PhD ready. He has more than 600 patients collection of these cases.
Yeah.
So they are desperate diseases.
He presented in Madrid last year, right, Luis?
Yeah. Yes.
Okay, shall we move on, Louis, to Pascal's talk?